Hi, I'm Dr. Rich. I'm teaching you about dentistry and teeth so you can have a very nice smile.
Thanks for joining me today. Today we're going to be extracting the upper second molar there. It's the upper right, and the tooth's got a large area decay underneath a big composite resin filling. And the decay was so bad that I actually snapped off the crown of the tooth before I realized that I didn't have the camera on. So now I got the camera on, and I'm using my spade proximator to work all the way around the tooth, try to get some movement. So these types of cases where the exposed part of the tooth is so decayed are more difficult extractions simply because there's nothing to push against on the tooth. I'm using the spade proximator. I'm just kind of forcing it down into the PDL space to try to get the roots of the tooth moving. But a lot of times the decay goes so far under the gum line that every time you try to, other than pushing straight into the space, if you try to rotate the instrument a little bit, the tooth ends up just crumbling because it's so soft and it doesn't offer any resistance. There you can see it. I'm trying to work it on the distal a little bit on the palatal. Again, just working it all around, trying to get as much movement as I can before I move on to the next instrument. Although this one definitely it's going to end up being a surgical extraction in this type of situation. Just cleaned up some blood so I could see a little bit better. And again, on the distal, now I'm able, as you can see, I'm able to get the head of the spade pretty far down under the gum line. So now that I did that, now I'm going to take my Dr. Murph crane pick and see if I can get any movement with this. So this instrument is designed for upper molars, to extract upper molars. You wedge it in between the tooth, so I'm actually pushing up against the bone, not the tooth in front of it, which has a crown you got to be careful with. I didn't have quite enough room for it, so I'm going to use a 301 elevator. So this is a stronger instrument than the spade proximator. Tip's a bit thicker, but the tip is also thinner than the Dr. Murph crane pick. So I find that sometimes in situations where I don't feel like I have enough space to get the Dr. Murph crane pick into the area in between the teeth, I'll use a 301 first to get some movement. And there you can see the 301 broke off a little bit of the tooth. So let me just use my surgical suction to help clean up the blood and remove it. Now I'm not getting as much movement, so we decided we're going to go surgical on this. I like to try to get it moving as much as I can, but sometimes once it doesn't, you got to know when to switch gears and turn it into a surgical extraction. I explained to the patient there's a good chance this was going to be a surgical extraction before we started. So I got my surgical handpiece with a straight Fisher burr on there, and what I'm doing is just cutting in the tooth in half. I'm separating the two buccal roots from the palatal roots. Once I cut the slot in all the way through, then I'm going to take back to the 301 elevator, stick it in between, give it a little gentle twist to break them, and then work all the way around, see which root wants to come out first. Sometimes you think it's going to be a certain root that'll come out first. Other times you're surprised when a different root decides to come out. But whichever one comes out first, that's the one we get. So got some movement. Now I'm back to the spade proximator, and let's move that in there. Got to clean up some of that blood, and it looks like the palatal root wants to come out first. So we're working back there. These types of situations are a little hard too. Person's got a fairly small mouth, and again, because the tooth is so decayed, I can't really get a good purchase point on the tooth. But it looks like we got the distal buccal root out, and there it is. Let me use my finger forceps to deliver it the rest of the way. And surgical suction tip. And it only looks like the person's very reclined. It's just because of the angle of the camera. It's a loop mounted camera. So got that root out. Once the first root's out, generally the next two roots are easier. Knock on wood and hope I don't jinx myself. So I'm using the spade proximator, and then next I'm going to use the 301, try to get that mesial buccal root out. And we got it moving. Again, it's just hard to get a good purchase point on what's left because what's left is so mushy. So every time you go to elevate it, a little bit breaks off, crumbles. You got to try to elevate a little bit deeper. So now we got a little bit more room. Let's take the Dr. Murph crane pick and see what we can get. Oh, and there we do. There we got it. There we got the palatal root. We had enough there. Got the whole palatal root out in one piece. Nice. So we're just left with the last the last buccal root. I'm seeing if I can grab it with my finger forceps. And that was just a little piece. Or is that the whole root? That looks like we got the whole root. Let me clean it up. It was loose in there from the Dr. Murph crane pick. So I like to suction it all up and then use my mirror to check for any openings into the sinus. So now we have the three pieces of the root, and then we have the 2 pieces of the crown that broke off prior to me having the camera going. And I'm just soaking them in some bleach. Just some patients actually want to bring the teeth home for some reason. They have collections of all their teeth. So just clean them up for them. And now this patient, I have pulled teeth on him in the past, and he, for one reason or another, always tends to have some type of issue afterwards. Usually some type of a dry socket. I don't know, he's just very prone to it. So I tend to always put some sutures in to hopefully help prevent that from occurring. We're just using a chromic gut suture, so that's a dissolvable suture. And we're just going to do, I usually either do a figure 8 over top of it, or sometimes I'll do a mattress suture too, but with an X in between to get it to help close it, help keep the clot in place. And so we're just going to do a couple interrupted sutures in this situation because of how it is. So there's the one. Just got to tie it, and you put 3 loops around your needle holder in one direction, 3 loops in the other direction, and then I do a couple loops again in the first direction again to tie the knot, and then I just clip off the long ends, the tag end, and then the rest of the suture. Tag end gets tossed out. Tag end is that loose end at the end. So now I'm just going to put one more suture in, and hopefully this will be it. So when you're placing the sutures, you want to go far enough down into the gingiva so you can get a good bite, so that when you pull on the sutures or any pressure on the suture, not that you want to tie them so tight, but any pressure on the sutures won't pull through the skin. If you put the suture needle in too close to the edge, then it has a chance it's gonna pull through and tear it, and then suture's not going to do anything for you. So let's take another bite back there. Although sometimes to get it in the right spot, you got to kind of play with the needle in the needle holder so you can access the area where you want it and get it. It's the further in the back of the mouth that you go, the more difficult it is to suture, for me anyway. So unfortunately, too, that seems to be where I'm more likely to suture, is in the back of the mouth. Front teeth tend not to need any sutures. So let's pull it through again, and then we just need to tie it and tidy up. Three loops one direction, 2 loops the other direction, and then I'll do another 2 loops back in the original direction again. And now sometimes, too, these chromic gut sutures aren't the easiest to use. Sometimes it feels very sticky when you're placing it. Alrighty, so now we just have some gauze, clean him up a little bit, and he's ready to go home. And here, let me just show you a close-up of the different pieces of what's left of the tooth, a little bit cleaned up. There you can see the crown there, you can see, and then these are just the pieces of the root. I think that last piece was actually the filling. And this is the last piece there. That's the filling material, the composite filling that was in it. So yeah, pretty gross, bloody surgical extraction, a little bit harder, a little bit more difficult one. Not a fun time for anyone. Thank you all so much for watching. Hopefully we'll see you guys in the next video. Appreciate all the support. Please give us a thumbs up and subscribe if you enjoy the channel. Thanks so much.